Taylor Kimberly is here. He is a critical care and vascular neurologist at the Department of Neurology at Massachusetts General Hospital. He is the Associate Director of the MGH Neuroscience Intensive Care Unit and is Assistant Professor of Neurology at Harvard Medical School. Dr. Kimberly's clinical interests focused on the critical care management of acute neurological and neurosurgical diseases. He co-leads a multi-site clinical trial in acute stroke, and his laboratory studies biomarkers of injuries and acute brain injury. Today he's going to be talking about gender differences in stroke prevention and outcome. Thank you, Dr. Kimberly.
Thank you. I'd like to thank Dr. Ed Manno and the Cleveland Clinic for the opportunity to talk to you today about gender differences in stroke prevention and outcome. My disclosures include funding from the National Institutes of Health, Remedy Pharmaceuticals, and the American Heart American Stroke Association, but none of these funding agencies had any role in the content of the presentation that I'm giving you today. So let's take a step back for a moment, and in order to talk about gender differences in stroke, it's important to recognize that stroke is a large public health problem that will only increase over time. And the proportion of women that will be afflicted with stroke will also increase. So what I'd like to do is take you through a hypothetical patient and describe to you each step of her care, from presentation to evaluation in the emergency department, to evaluation and diagnostic studying in the hospital, as well as her post-hospital recovery. And at each of these stages, we'll use the case example to highlight some of the key areas in health disparity research that have identified areas of improvement in stroke care as it relates to women. So let's start out with our case study. She's a 76-year-old female, and she develops sudden onset word-finding difficulty, or aphasia, right facial droop, and right arm hemiparesis. She has a history of atrial fibrillation, and among her medications is warfarin. So what are some of the differences in how women present with stroke? A, they are older at presentation. B, women have more comorbidities compared to men. C, they are more likely to present with atypical symptoms. D, all of the above. Or E, none of the above. The answer is all of the above. In order to put stroke in women in context, let's take a moment and first talk about overall stroke incidence. In the United States currently, there are 795,000 strokes that occur each year. A vast majority of these are ischemic strokes, about 87%, or 690,000 ischemic strokes per year. The remainder are hemorrhages and subarachnoid hemorrhage. Ischemic stroke is the fourth leading cause of mortality for patients in the United States and a leading cause of morbidity. Importantly, women account for more than half of all ischemic strokes. And in terms of individual patient numbers, women have about 55,000 more strokes each year as compared to men. Well, what are some of the details in the sex differences in stroke incidence? Well, it's a U-shaped and age-dependent relationship. Women who are less than 45 tend to have a higher incidence of stroke relative to men. But it's important to acknowledge that patients in this age group, it's very uncommon to have stroke. In the 45 to 75 age range, women have a lower incidence of stroke relative to men. But again, the total incidence of stroke is a smaller proportion as compared to age 75 and greater. And in fact, as you look at patients who are 85 years of age and older, women have an equivalent, or in many cases, in several of the studies, a higher incidence of stroke. And because stroke is most common in this older age range of 75 and older, or even 85 and older, women disproportionately carry the burden of total stroke. Well, what about some of the characteristics of women who present with stroke? As I just mentioned, on average, they're older, and it's about 4 years older at presentation. Women also have worse pre-stroke disability compared to men, and they're more often living alone or in an assisted living facility. And in general, they have fewer social supports compared to men who present with stroke. They also have different risk factors, and these include, like in our case example, higher rates of atrial fibrillation, higher rates of hypertension, and lower rates of coronary artery disease, myocardial infarction, and diabetes. So let's return to our 76-year-old woman. After she develops her sudden onset aphasia, right facial droop, and right arm hemiparesis, she is rapidly transferred to the nearest emergency department about 2 hours from her last seen normal time. What would be the next appropriate step in her care? A, observe closely for neurological deterioration. B, administer intravenous tissue plasminogen activator, or IVTPA. C, obtain the NIH stroke scale score and a stat head CT. D, discuss goals of care with family members. Or E, none of the above. The correct answer is C, to rapidly obtain an NIH stroke scale score using the NIH stroke scale card, as well as arranging a stat head CT, the purpose of which is to evaluate and rule out for hemorrhage as the cause of the acute neurological deficits. In fact, rapid evaluation and treatment is the cornerstone of any patient who presents with an acute neurological deficit that could be consistent with an ischemic stroke. In 1995, when the FDA first approved IVTPA for the use in ischemic stroke, it was recognized that patients need to have coordinated care from many segments of the healthcare system, including emergency medical services, emergency departments, vascular neurologists, neuroradiologists, and that the numerous steps required were complicated and often took a fair amount of time. Because TPA was approved for only 3 hours, this made it difficult to achieve treatment within that time period. This led to the development of time-based targets in the evaluation of stroke patients, and the tracking of these time-based targets has dramatically improved the overall rates and safety of treating acute stroke patients. As one example, the National Target Stroke Initiative that was developed by the American Heart, American Stroke Association created a list of 11 steps that were recommended to primary stroke centers to focus on improving the overall process of evaluating and treating acute stroke patients. For example, some of these key steps include EMS pre-hospital notification, where emergency medical technicians inform the arriving hospital emergency department of a patient that may be having an acute stroke. Another example is the rapid activation of a dedicated stroke team that is available 24/7. The rapid transfer of patients into the CT scanner to rule out intracerebral hemorrhage, and in some cases even the pre-mixing of TPA so that it can be administered as soon as the decision is made that a patient qualifies. The basis for time-based targets is well-founded by the literature. There are numerous studies that have shown that the therapeutic benefit of intravenous TPA is greatest early on, and that this gradually declines over time. In the graph shown here, these data are pooled data from several IV TPA trials, and what it shows is that the odds ratio of a good outcome, which is defined as a modified Rankin score of 0 to 1, that odds ratio is highest early on and gradually decreases, such that the 95% confidence interval, which is delineated by the blue lines, crosses the line of unity at about 4.5 hours. Part of the reason for this time window is that if TPA is administered at later time points, the risk of hemorrhagic transformation and symptomatic intracerebral hemorrhage increases, and any potential benefit is outweighed by the risk of this hemorrhagic complication. Now, these data are from several pooled randomized controlled trials published in The Lancet in 2010. But it's important to recognize that in addition to the pooled clinical trial data, that there's very similar experience in a more generalizable and large nationwide registry of stroke patients. Well, what are the sex differences in acute therapy? Clearly, IV TPA has a role in patients who present within 3 hours, which is FDA approved, and although not FDA approved, most stroke centers will extend that treatment out to that 4.5-hour window based on the data that I showed you. Importantly, initial studies had indicated that women were less likely to receive IV thrombolysis. And this disparity in treatment represents a potential area for improvement. And although the age may account for some of these differences, the study suggested that additional confounders may contribute, including, for example, the greater likelihood that women present with atypical symptoms that may not be recognized as an acute stroke. Intriguingly, intravenous thrombolysis, while it's clearly beneficial to both men and women consistently exhibit a larger treatment effect size than men. So the fact that women were not receiving IV thrombolysis represented a missed opportunity to reduce the burden of stroke in women. Fortunately, recent studies have suggested that this sex-specific thrombolysis difference has shown a gradual reversal, where in 2003, less than half of all patients who were treated with TPA were women. By 2011, that trend has reversed, and now slightly greater than 50% of women are treated with TPA. So let's return back to our case study, our 76-year-old woman with left hemispheric syndrome leading to neurological deficits on the right side. Because she arrived within the 2 hours into the emergency department, that allowed the ED and acute stroke team to evaluate her and obtain a head CT and make a treatment decision on TPA. And after administration of the TPA, she was admitted to the hospital. The main reason is not only to monitor for hemorrhagic transformation, a known risk of IV TPA, but to evaluate for the underlying cause of the stroke. The in-hospital diagnostic procedures are one potential area of disparity between men and women. Which diagnostic procedures are women less likely to receive? A, lipid level measurements. B, transthoracic echocardiography. C, carotid endarterectomy, D, carotid ultrasound, E, all of the above. The answer is all of the above. And the sex differences in in-hospital diagnostic and in-hospital diagnosis and therapy has been studied by several studies, and there is a consistent finding that women tend to have fewer in-hospital diagnostic procedures compared to men. However, it's important to acknowledge that the magnitude of these differences is generally small. Some of these include lower rates of carotid ultrasound, lower rates of transthoracic echocardiography, and even lipid level measurements. However, after adjustment for age, these differences generally are not significant, with perhaps the exception of lipid levels in one study. Even in the context of lipid level measurements, however, there's no consistent difference in the prescription and use of statins at discharge between men and women. So even if women are not having their lipid levels checked quite as frequently, they are being discharged on a statin at a similar rate compared to men. So we return to our case study of our 76-year-old female, and after her hospitalization, after her monitoring for her TPA treatment and her in-hospital evaluation, what is more likely to happen after discharge as compared to men? A, discharge to home. B, she'll have a lower quality of life compared to men. C, she'll have a lower rate of depression, of post-stroke depression compared to men. D, she'll have a better modified Rankin scale score. Or E, none of the above. The answer is B. She's more likely to have a lower quality of life. Several studies have focused on sex differences in outcome, and a consistent finding in all of the studies is that women have poor outcome relative to men. They also have less favorable quality of life after stroke, and they have higher rates of post-stroke depression. Even though women are older when they present with stroke, and they are more likely to have comorbidities and less social support, adjusting for these differences do not fully account for the less favorable outcomes that women consistently have. And this really represents a key area for further study in order to understand the underlying causes for this difference in outcome. Well, what about prevention? This too has been an area of significant research. In primary prevention, where the goal is to prevent a first stroke, there are indeed sex-specific differences in the effect of antiplatelet agents. So, for example, women, the use of aspirin reduces the rate of first-time ischemic stroke, but not myocardial infarction. And the inverse is true for men, where an aspirin doesn't have an influence on the first rate of ischemic stroke, but it does reduce the rate of first-time heart attack. The basis for this sex-specific effect is not well understood, although sex hormones may play a role based on their differential effect on platelet activity. For secondary prevention, antiplatelet agents, when it's appropriate to use antiplatelet agents, they appear to have similar efficacy for both men and women. Similarly, anticoagulants, whether traditional oral anticoagulants like warfarin or the newer generation oral direct thrombin inhibitors and factor Xa inhibitors, these have a similar efficacy for both men and women when appropriately prescribed. So in summary, women carry a larger burden of stroke, and a major reason for this is due to their longevity and their older age. There are differences in the risk factors that women have for stroke relative to men. They have a higher prevalence of atrial fibrillation and a higher prevalence of hypertension, whereas they have lower rates of coronary artery disease and diabetes. Women have a higher mortality rate that's attributed to stroke, and they have worse functional outcome. The identification and correction of modifiable factors, which include the rate of intravenous thrombolysis, as well as identification of appropriate secondary prevention, each represent important areas to reduce the disparities in treatment of women compared to men. Finally, the identification of causes for poor outcome that women have, even after adjusting for known risk factors, affords the opportunity to improve the care of women who suffer from stroke. As stroke is anticipated to increase in incidence overall, and with the expectation that women will continue to carry the larger burden, understanding each of these disparities and working to reduce them provides one very important way of reducing the overall burden of stroke in the United States. I'd like to thank you for your attention.
Thank you, Dr. Kimberly, for this discussion on this important topic. I think this is going to be an important area in stroke as we move forward. I would stay tuned to research in this area. Again, thank you, Dr. Kimberly.